Thank you, Dr. Spade, and I want to thank Kuwait Society of Nuclear Medicine for inviting me to this session. Let me just ease your attention, Dr. Spade. We're going to keep FFR for you for now, but we'll take the CFR from you. Okay, so I'm going to talk about coronary flow reserve by PET. I think this is a more advanced field at this point. There are a lot of work going on with CFR by PET estimation. Dr. Kaufman Group just presented an abstract in ACC using the CZT camera, and it's a lot of promising work, but I don't think it's ready for prime time yet. I think coronary flow reserve by PET is far more advanced, and this is what I'm going to limit my talk to. I'm going to begin with a just quick introduction about cardiac PET CT, where you can do a lot of applications with cardiac PET CT. You can see we can do perfusion, we can do calcium score if you have a hybrid system, image fusion, obviously viability, which you will have a lecture about later on, and what I'm going to focus on is mostly the first pass and the utility of that in clinical cardiology. So cardiac PET is much more has a lot of advantages because it provides high image resolution. We have superior time efficiency because we can do all our study in about 25 to 30 minutes. It's much less radiation compared to SPECT imaging, and there's a lot of data to show that it has superior ability to delineate extent of coronary disease, and this will be the focus of this talk in here. There are multiple radiopharmaceuticals that are already approved for this. There's O15 water, which requires a cyclotron, ammonia, and rubidium-82, which requires a generator. Flurpiridaz, which is the F18 agent, is not yet FDA approved, and that's why I didn't put in here. And the recent meta-analysis published in JACC last year clearly shows that PET imaging, according to this meta-analysis, is the most accurate test available compared to all other myocardial perfusion imaging. In this meta-analysis, it shows it's much better than SPECT, and it's also better than CMR perfusion imaging. And this is the protocol that we are doing. We usually start with the SCOUT, get a CT attenuation correction. We inject a very small dose of rubidium because we have a 3D system. We acquire our data in the list mode, and then we can unlist the data again to do a static, gated, and the dynamic. Then we do our dipyramol injection for 4 minutes, wait for 3 minutes, get our second injection, image acquisition for 7 minutes, and we finish up with the CT attenuation correction and calcium score. And then for the dynamic image acquisition, we do unbin our data into multiple phases, and these phases are different times. So you can see here at time 10 seconds after injection, where most of the radio tracer is in the RV, then it goes into the LV, and then it goes into the myocardium. So we try to get different compartments, and you can measure these by hand, as what I was doing when I was doing my fellowship not too long ago. But now we have multiple tools where we can draw these time activity curves and get the flow reserve, the amount of flow. There is a lot of kinetic modeling in there. I'm not a physicist, so I'm not going to go into the details of this, but I can tell you that O15 water and rubidium use a single tissue compartment model, while ammonia and flurpiridaz are using the two models in there. And now there are multiple software that are available that allows you to do the CFR quantification very quickly. And in this review of Journal of Nuclear Cardiology a few months ago, they did a nice job reviewing all these software. I'm not a commercial guy trying to sell you one versus the other, but there are at least now 15 software available. And you can see here what we were used to do in about 45 minutes to get the CFR now is really a button click. I can tell you I am using this software and it takes about 2 seconds, between 2 to 10 seconds at maximum to calculate the CFR. It's not even 2 minutes as listed in here. But these are the lists of software, and you can see how many software we have available now to do that. One issue that always comes up is rubidium well suited to do this versus ammonia. Obviously ammonia is better, but at least you can get reasonable numbers with rubidium that correlate very well with ammonia. This is the study that we did when I was in fellowship, where we brought normal volunteers that we announced for on the Harvard Medical School website, and these people had 2 rubidium studies. and then they went to MGH and got 2 ammonia studies, and we compared the reproducibility within the same patient and then between ammonia and rubidium, and you can see here there is good correlation. It's not, I wouldn't say it's excellent, but it is at least with an R-square of 0.76 or a little bit higher. And then you can see that there is a good correlation with MRI, myocardial blood flow, which takes so far still much longer time to determine. So one thing to keep in mind when we're looking at this is that there are a lot of factors impacting myocardial blood flow by PET. There are some technical issues which depends on the radio tracer you're using, the acquisition scheme and the type of model and the different methods you're using. But there is also the type of stress you're using, the completeness of the preparation of the patient, and then there are obviously the biological factors, the age, the hypertension, left ventricular hypertrophy, obesity, and resistance, and diabetes mellitus. So if we have this much variability, currently what are the absolute indications for myocardial blood flow? I don't think there is an absolute contraindication. That's why I left the slide empty, because I don't think we 100% need it clinically, but there are a lot of ways where it does help you sort things out between one versus the other situation. But sometimes it brings more confusion, and I'll show you some cases where it does help us and some cases where it does confuse us. We started our PET program about 18 months ago, and last time I was here we were just recently started, so now we've done about 251 viability cases, and we've done close to 1,000 cases with perfusion rubidium. We're doing about 150 cases, and we do quantify blood flow on every single patient because it really doesn't add anything to the patient in terms of radiation exposure or time. The software is there, so it's bonus information that's really coming up for this patient population. So where is potentially helpful? I think it does help us first with quality assurance. When I see that the patient flow increase between stress and rest, I'm reassured that the patient followed the preparation. We had some patients sometimes come to us with coffee in their hand and they're coming for myocardial perfusion imaging with dipyramide or adenosine, but sometimes they are smart enough to throw it just before they get to the door because they know and they tell us that they did not drink coffee for 24 hours. And this is where we can detect these patients, because if we see the myocardial blood flow the patient had good hyperemic flow, then this is good quality assurance in there. Also in terms of CAD patients where there is better extent and delineation of coronary disease, and it does provide us with better evaluation for the patients with chest pain, which I'll show you some cases for. And then the final thing is in terms of heart failure, because if you have a segment which is hypoperfused, but then potentially there is significant increase with stress, this is another sign that there might be enough viability in that segment, and Dr. Kaufman might elaborate on this in his later talk. So where do I use myocardial blood flow and CFR in my clinical practice? There are few cases in here. The first one is if you have unclear cause of TID or abnormal EKG with normal perfusion, and this is, for example, a case where you can see here that there is significant TID. The TID ratio came up to 1.4. The ventricle looks wider here or larger in the stress images. This patient had normal myocardial blood flow. We were pretty certain that there is nothing much going on, but then when we went ahead and did cardiac CT for the patient, you can clearly see that the patient has normal coronaries in there. So obviously this patient had normal myocardial blood flow in there. The other situation where I find it extremely helpful is determining the extent of coronary disease. You can see, you all know, and you struggle like me when we read these nuclear scans, are we dealing with one vessel or two vessel or three vessel disease? This is data from Dan Berman, where he clearly shows that even when you use the best clinical indicators that you have, so when you add the percent myocardial perfusion, plus ejection fraction, plus multiple defect, plus lung uptake, plus abnormal wall motion, on top of it a TID, you're still missing 17% of three vessel disease. You label them as one vessel disease when in reality they might be three vessel disease. So this is a little bit concerning, and here's one case here where if you can look at this, everybody will read this as a circumflex, but no evidence of ischemia. And if you look hard at it, it's still gonna look the same. No matter how much you look at it, you're not gonna find any hint in this patient that this is anything more than just a single infarct. But then when you go ahead and look at the myocardial blood flow, you can see in here that the flow did not increase between stress and rest. So you can see the CFR is severely decreased in all three vessels. And this patient, when he went for angiography, he does have three vessel disease. So we can tell, and this is what I tell my colleagues in here, if you're looking at just some images from SPECT, you might easily underestimate the amount of disease in these patients. And this could be a case where you can say this a pseudo-balanced ischemia because the two viable vessels have decreased flow in there. And this is data from the Ottawa group where they clearly showed that if you use myocardial blood flow, you increase your detection of three vessel disease, where you can see here that if the blood flow is at 1.5, the CFR is at 1.5, then the chances of three vessel disease is about 25%. When it drops down significantly, it does increase the chance of three vessel disease. And when they did the ROC analysis, you can see the CFR adds to our normal ways of estimating ischemia in these patients. Here's another case where you can look at this. This is a recent case where we had in our lab, where you can see that if we look at this, you can see that the anterior wall looks fine. There's small apical defect, and there's another septal defect, and then on this rubidium PET. But if you look at it, you would never guess that this patient had three vessel disease. This is, you can argue that this patient even has like single vessel distal LAD disease. And when you go ahead and look at his coronary flow reserve, you can see that his flows did not increase between rest and stress, and his flows are down all through. And this is confirmed on angiogram, where you have multiple lesions here. The LAD was proximally occluded, and there is actually a circ lesion which turned out to be hemodynamically significant by FFR. So balanced ischemia is another concern that you can detect in these patients. Another issue that comes up is looking at the prognostic information in these patients. And now we know that just simple summed images from PET add significant information. This is a recent publication just published a few months ago from a registry of 4 centers with 7,000 patients, where they show as the perfusion defect increase, there is increased risk of cardiac death or cardiac events among the different groups. But when you add myocardial blood flow in these different studies that looked at this using either rubidium or ammonia, you can see that there is increase in the event rate even among patients with normal perfusion. And this is, you can see here that the hazard ratio varies all the way to up to 5.6 from 1.6. And these studies use different numbers of patients. The largest one is the one coming from the Brigham group with the longest follow-up, and they had multiple subgroup analysis now either presented or published so far. So the challenges, this is not always a glory picture. So there are some challenges with that. The most important challenge is that CFR might be down in patients with risk factors without epicardial coronary disease. And this is the microvascular dysfunction. And this is data from the Rampart study presented by Marcello Di Carli and published in JNC in 2004, where he clearly shows that among patients with with dyslipidemia, you can see decrease in myocardial blood flow irrespective whether they had epicardial coronary disease or not. Similarly with diabetics, the CFR is going to go down. And this is where the problems comes. Shall we send patients to coronary angiography just on the basis of a low CFR? We don't do that, and every person that I talk to, they don't do it unless you have other hints that the patient has something else going on. So patients with normal perfusion and decreased CFR do not warrant further workup. We know that they are higher risk based on the outcomes data that has been presented and published, but they don't need further workup in terms of angiography or revascularization. And here's a patient who we know that by angiography has a normal LAD and RCA, but you can see the LAD and RCA are equal in terms of decreased CFR to the circ, which has a tight lesion. Although you can argue that the circ is the worse CFR, but you can see here the LED and this RCA are not in any better shape. And this patient has diffuse disease and probably microvascular obstruction in the LED and circ despite having normal angiography in these vessels. Another situation where we find out that our patients decide to stop their medications 1 to 2 days before they come to us for nuclear stress testing. So they come to us with a blood pressure of 180 or 190, and then their CFR, their flows at rest are going to be high. This is a patient who clearly has normal perfusion. But when we did her CFR number, we did calcium score, and calcium score is 0. When we did her perfusion, the numbers looked a little bit down if you look at the numbers here. It's coming as a reserve of 1.2. So what's the problem with that? When we look at her true numbers, you can see that her rest flow is elevated, but her rate pressure product, at the time of the rest perfusion, her pressure was 180. So her rate pressure product was about 14,000. And this is where we are now learning that we should probably normalize these to a rate pressure product of 8,000 or so. And this is what other groups are doing. So once you correct for that, now you see that this patient who was able to increase her flow, now her CFR is normal. And this lady did have angiography and she had normal coronaries. Another issue that always comes up, which is more important, the absolute number or the ratio? Is it the peak myocardial blood flow or the ratio? And why is that is important? Because sometimes you have patients with severely decreased resting blood flows from cardiomyopathies and others. So with vasodilator, just minimal increase will give you a normal CFR, but these patients will barely have a peak flow of 1. So what do you do with these patients? At least there's not a lot of published data about this, but this is data from the Turku group, which was presented last year, where they showed that it looks like the absolute flow has better correlation with outcomes in terms of long-term data. There are also other issues regarding all the methods that have been used and these different software that are available. The good news is that there are all these methods in terms of outcomes. They predict outcomes the same. This is actually the abstract that won the Young Investigator Award last year at the American Society of Nuclear Cardiology meeting, where they looked at about 3,000 patients, where they looked at CFR and the prediction of outcome. And what you can see here, that the annualized cardiac mortality does not differ much irrespective of the way you determine your myocardial blood flow in these patients. So in conclusion, it looks like this myocardial blood flow and CFR are a powerful tool that could assist in the management of patients with suspected CAD. There are still some issues with them. We still don't know exactly where to put them in the management of these patients, especially with management skills. It looks like more work is still needed to define their role further. With that, I'm going to stop and thank you very much.